All right, so we're in chapter 35. Chapter 35 covers antihypertensive drugs. So within the overall class, remember we talked about drugs can be classified based on what they do or their chemical makeup or, any of these different means. For these drugs, we're classifying them by their action, by what they do. They're antihypertensives. They're going to lower blood pressure, okay? So because we're classifying them by what they do, there's going to be a whole bunch of different classifications beneath that big umbrella of antihypertensives, okay? So we're going to be flipping back and forth to chapter 25. Chapter 25 covers adrenergic blocking drugs, which are under that umbrella of antihypertensives, okay? So you are going to refer to chapter 25. And then most of the other stuff is going to be within these other chapters. But if I start talking and you're not seeing it in your book, just put a little dog ear on chapter 25 because I'm going back to that, okay? And I'll try to make sure y'all know where I am as I'm speaking. All right, so when we're talking, before we say anything else, everybody knows what hypertension is. Hypertension is elevated blood pressure. Everybody knows that what hypertension is classified as far as if I gave you a blood pressure, would you be able to tell me if it was in the hypertensive range or if it was normal or hypotensive? Okay, so hypo, low, hyper, high, normotensive is regular. So 120/80, everybody gets hung up on that number. That is kind of that's a middle ground for you guys to go off of. If they're 122/78, they're absolutely still normal, okay? And that number has changed over the years. But for our purposes, in my class, you'll refer to that box on page 395. 100 less than 120 is normal. Stage 1 hypertension is going to be 140 to 159-ish range. And then stage 2 hypertension is going to be greater than 160. So we know kind of those ranges in our head. Normally in a hospital setting, if our systolic is over 160, we're calling the doctor to get some further orders, or bringing it to his attention. We're not generally calling him if it's 140, even 150, okay? That's not something that we are really anxious about. We're going to make note of it and we're going to document it, and monitor it accordingly, but we're not going to call the doctor about it. If in a clinical setting as a student, you do need to notify your nurse and your instructor. Anything that's out of range at all, just kind of as a heads up so that they know that that it's out of range and it's not necessarily normal. So we're talking about patients who have hypertension. I feel like y'all probably already know this stuff, so I'm going to kind of blow through it. Y'all know the risk factors for hypertension, correct? Did y'all learn that previously? We live in Louisiana. The food we eat puts us at risk. Our weight puts us at risk. Family history is huge. Sometimes you can be the healthiest little person in America, but your family history just puts you at a disadvantage and you have super duper high blood pressure. Lack of physical activity, chronic alcohol consumption, and then being African American increases your instance of hypertension as well. So, excuse me. So we kind of all know what high blood pressure is, what hypertension is. So we also know how many people, I don't have numbers, but I think it's like 2/3. I might be lying. I think it's like 2/3 of Americans will have hypertension in their lifetime. So as a nurse, you know that you're going to take care of lots and lots and lots of people with hypertension. So it's your job to know what these medications do. It's your job to know whether or not you should give them or shouldn't give them. And it's your job to know what to be looking for as far as adverse reactions. There's a word that I think I failed to discuss with y'all. Do y'all know what contraindicated means? Did y'all learn that in medical terminology? Contraindicated means it's not suggested for this patient. It's contraindicated in pregnancy or, with patients with these conditions. I'm not sure I've told y'all what that word meant previously in case you didn't know. So I'll be saying that a lot because blood pressure medications are contraindicated in some people. So I'm going to go ahead and start sharing my slide. I probably won't be able to see y'all. Sometimes I can see you guys at the bottom. It lines y'all up pretty for me. And sometimes once I start sharing my slide, I can't see y'all anymore. So, chapter 35. All right, so we know that blood pressure is the force of blood against artery walls. That is how it's measured, and that's where it comes from. So we're talking artery walls, you know, intravascular spaces, not outside, extravascularly. High blood pressure that stays elevated over time is called hypertension. So one reading of your pressure being high when it's checked at a random place does not mean that you have hypertension. It is repeated readings and it's staying elevated over time. So this says 1/3 of adults have hypertension. I said 2/3. I'm sorry about that. And I actually probably think that's an underestimate, to be honest with you, because pretty much everybody I know in my life has a little bit of hypertension. And then African Americans are twice as likely to have hypertension. Y'all can see my PowerPoint, right? Give me a thumbs up if you can. Okay, cool. I've already told y'all this. We talked about the stages of hypertension, but there's a difference between primary hypertension and secondary hypertension. Primary hypertension is when a patient it doesn't have a known cause, and your blood pressure is just elevated. It's not secondary to something else. It's not because of something else. Secondary hypertension is you have another diagnosis that causes your hypertension. So somebody with kidney disease with a lot of fluid retention, they still have hypertension, but it's secondary to that kidney disease because the kidney disease is the primary diagnosis. You're not ever really going to have to differentiate between the two of those, but you will see those different diagnoses on your patient care plan, so it's just nice to know. We've already talked about this. Systolic blood pressure less than 120 and diastolic less than 80 is considered normal. We know that hypertension, if left uncontrolled, can lead to heart and kidney disease, heart failure, and stroke. And we know that pre-hypertension exists when the blood pressure is 120 to 139 or 80 to 89, and patients should be placed on lifestyle modifications. So generally, they're not just going to throw you on medications when your blood pressure, you know, is the 120 to 140 range. They're going to say, you know, let's maybe lose a little weight, decrease your salt. So that's part of your education as a nurse, is to encourage those lifestyle modifications. So non-medication treatments of hypertension, weight loss, stress reduction, exercise, smoking cessation, decrease in alcohol consumption, and changes in the diet, like I said, decreasing sodium. So at some point, you know, these non-medication treatments, we hope that they'll work, but at some point, if they do fail, then we're going to move to pharmacologic treatment of hypertension, which is what we're going to be talking about today. So if you look on page 394, you see those drug classes there? All right, drug classes of antihypertensive drugs are beta-adrenergic blocking drugs, alpha-beta anti-adrenergic blocking drugs, calcium channel blocking drugs, angiotensin converting enzyme inhibitors, and angiotensin II receptor antagonists. And then you can add to that list on page 35, just for your personal knowledge, diuretics. So we'll be discussing those too. All right, so we're probably at the point where none of that sounds familiar, does it? Does any of that sound? I'm gonna stop sharing my screen so I can look at you guys for a second. Do any of those terms sound familiar? Beta-adrenergic, alpha-adrenergic, does this sound like brand new information? Thumbs up or thumbs down? It's okay if it sounds.
And
Okay.
Angiotensin.
Okay, heard the words, but don't really know what they mean kind of thing. Okay, so I'm going to exit the PowerPoint and I'm going to give like a little mini lesson. Remember I told y'all when we were doing, you might not remember, but whenever I said we kind of briefly touched on the way that drugs work, they're either agonist, antagonist, and we talked about Narcan just for a little minute, and I said we'll talk about this later, just know the words for now. So I keep dropping my little thing. So, and within the body is pretty amazing. So y'all learned in A&P about synapses, and y'all learned about how the body sends a signal to this to do this, and the body, there's certain receptors in the body that aren't going to do anything until a catalyst tells them to do something. Do y'all vaguely remember that in super simplified terms as far as nerve impulses went? Medications are the same way. You have receptors in your body. So outside of medication, you have receptors in your body for pain, for hunger. Remember, this is how we feel pain, how we feel hungry. And we have receptors in our brain, and that's why, whenever certain chemicals are imbalanced, that's why we have depression. So all of these things, your body has receptors all over the place. So normally what would happen, your body, you have like a little receptor in your body, and your body would have that synapse, and it would use some kind of chemical here, and it would fit right in there, okay? And that's how then something else would happen once this receptor was targeted, and then something else would happen. So medications are kind of the same way. So I heard y'all talking, it worked out for me wonderfully, because I was in the room when Miss Adams was lecturing on the RAAS system the other day, RAAS. Remember when she was saying that? It's so perfect that she's teaching that right now, because it's so important to know that to learn about these hypertensive drugs. So as far as the RAAS system goes, we're not going to go through, and comb it out with a fine tooth, whatever it's called, comb it, whatever. I can't even say the little saying. But do y'all remember very specifically how this causes this to happen, and this causes this to happen, and then from there this happens, and then angiotensin 1 is converted to angiotensin 2, and then thereby the blood pressure is increased. And it's very much a methodical step-by-step process. This causes this, causes this, causes this, and then the blood pressure increases, or sodium is retained, or, at whatever point of that process we're in. So I'll talk a little more about RAAS in a little bit, but we understand that something is causing something else. So when we're treating hypertension, some kind of way, we have to interfere. We have to come in and we have to either take that receptor that is expecting something else, and we either have to block it right here with a medication so that it can't move on and it can't follow in that systematic step that it was normally going to take, or we have to fill it with something else and let it carry on with that step, or we can partially fill it. And then it can still, and then this is simplified, but we could partially fill it, and then those other steps can go, whatever those steps are. So that's an agonist is going to cause, and it's going to attach, and it's going to cause something to happen. An antagonist is going to block it. Therefore, the original, response that you wanted, it's blocking that original response. So agonist is coming in and it's filling that space. Antagonist is blocking it. And then a partial agonist would be part of the way. So when we're talking about these words, you're going to hear me say beta adrenergic blocking drugs. So we'll know those beta cells within the body. I'll give you a brief idea of what beta cells do. So if we're giving a beta adrenergic blocking drug, our goal for that drug is to block that beta cell response, because it is a beta adrenergic blocking drug. Does that kind of make sense in a very simplified way of how these drugs are going to work? So the same thing is going to be, so let's just take those drug classes before we do anything else. Beta adrenergic blocking drugs. So there are beta cells in the body, and they are very much involved with regulating fight or flight. Okay, so what happens? Y'all remember fight or flight? Okay, what happens whenever we activate fight or flight? Does anybody know? What is your body's normal response? I said quiet. Okay, fight or flight. Are we speeding up or are we slowing down? We're fighting. We're like Rocky, y'all. We're speeding up. Okay, our heart rate is going up, right? Because we're in that fight or, do y'all know what fight or flight is? Y'all got to communicate with me a little bit so I don't keep teaching and y'all are lost. Y'all know fight or flight. You know the responses in the brain, and your body is either going to, your central nervous system is going to kick in. So fight or flight is when you kick it into high gear. Your heart rate goes up, your blood pressure goes up. All of those things go into into survival mode. And then the parasympathetic is the opposite. Everything kind of slows down. So adrenergic, the adrenergic response is that fight or flight response. Y'all might want to kind of write that down to keep it like that in your brain. Adrenergic response is fight or flight. And that's involved with the sympathetic nervous system. And the sympathetic nervous system regulates involuntary functions. And I already told y'all it results in an increased heart rate and an increased blood pressure. So when we're given the first class of antihypertensive drugs we're going to give are going to be beta adrenergic blocking drugs. So if we are blocking that fight or flight response, not the whole response, but if we're attaching to those receptors, those beta receptors, what do you think is going to happen to heart rate? If we're blocking it, the normal response is to increase it. The normal response of the body is fight or flight. But if we are giving a beta adrenergic blocking drug, what are we doing to heart rate? Bringing it down. What are we doing to blood pressure? Bringing it down. Does everybody understand that? Okay, so that is the first class, beta adrenergic blockers. We call them just straight up beta blockers. Okay. Alpha beta anti-adrenergic drugs are going to do the same thing. An anti-adrenergic is the same thing as an adrenergic blocking. Does that make sense to y'all? Anti-adrenergic, same thing as a blocking. Essentially, there's differences. I always simplify things a whole lot for you guys because we're not in molecular biology right now. I just need y'all to know that we're targeting certain receptors and we're either wanting, your job as a nurse is to know what is our goal. Our goal, if we're given a beta blocker, is either to decrease the heart rate or decrease the blood pressure. And so that's really kind of as deep as we're getting into it as far as that goes, but you at least have to have an understanding of that. So anti-adrenergic, there's also alpha cells that are targeted in those fight or flight type responses. And so if it's an anti-adrenergic drug, it's also going to be blocking those things, similarly decreasing the blood pressure. Okay. Another class, which we'll go into depth a little bit, is calcium channel blockers. What have you guys learned about calcium in Miss Adams' class? I see you talking, Kels, but I can't hear you.
We talked about like the range and the effects of having too much of the less.
One more time, I didn't hear you. Talked about what?
We talked about the range of calcium, like in the correct range, and then like the effects of hypertension or hypercalcemia and hypocalcemia.
Okay, what is something that happens with hypercalcemia? Or if, let's just say, if the calcium is out, have y'all noticed that that it involves the muscles? Have you guys noticed that at all? The tetany and all the different things that are going on with calcium, it targets the muscles in some way or another. So calcium channel blockers, calcium is very much involved in smooth muscle. and the heart has smooth muscle, and also within on the exterior of your vessels, there's smooth muscle. So that is another type of drug that we're going to use for hypertension, and we'll go into more depth in a little bit with that one. Then we talked briefly about ROS. So angiotensin converting enzyme inhibitors. So if the goal of when during the ROS process, we have angiotensin 1, angiotensin 2, and we have to have the ACE to convert angiotensin 1 to angiotensin 2. If we block that conversion, remember our end effect of ROS is what? We're increasing the pressure, right? At the end of the day, it's a whole big process, but we're increasing the pressure because of aldosterone and because of angiotensin 1 and angiotensin 2 leading to that aldosterone. So if we're blocking angiotensin 1, if we're inhibiting ACE, which changes angiotensin 1 to angiotensin 2, if we're inhibiting that, then we're thereby blocking part of that normal response, and our pressure is going to come down. So are we kind of on the same page? Is it making sense? You might have to look through those steps, but when we look, and I'll try to post, let me make a little note. Are y'all not as familiar with ROS as I think y'all are? Do I need to post like a little something drawn out and point right here that says, if this is blocked, then we don't go to this next step? I want to say, I feel like I know it in my head, but I don't want to tell y'all the system. I know that ACE changes angiotensin 1 into angiotensin 2, and then aldosterone is reabsorbed by the kidneys, but I don't want to get it all mixed up for you guys. But at the end of the day, when we go through that, that do, everybody agrees that the end result is increased blood pressure. So if we are somehow interfering with that, we're going to result in decreased blood pressure. Converting enzyme inhibitors, so we're going to block it there, or we're going to have angiotensin 2 receptor antagonists. That means that we're blocking it, we're letting that, it's changing from angiotensin 1 to angiotensin 2, but then we're blocking it there at the end. So all of these meds, all blood pressure medications work in one of these ways. The other class that mentioned that's not in this specific chapter, but that we're going to talk about specifically is diuretics. So I also heard Ms. Adams talking to y'all about sodium and water retention, right? So if we're retaining sodium, then our let me just read this to you because I want y'all to write this down. Okay. Aldosterone causes an increase in salt and water reabsorption into the bloodstream from the kidneys. Thereby increasing blood volume, restoring salt levels, and increasing blood pressure. So if we, with our diuretics, I'm not going to go too much into them right now, but with our diuretics, if we can withdraw some of this salt and water from those intravascular spaces, our blood pressure will also decrease. So all of that to say, I'm going to go back to my PowerPoint. When I'm reading this stuff to you and I'm going through it, that's a general overview of how blood pressure medications are going to work. The ultimate goal is going to be to decrease the blood pressure. But at the end of the day, they're not all going to work the exact same way. That's 1, 2, 3, 4, 5. That's 6 classes right there that I just told you guys about of different types of medications. Just for antihypertensives. And the reason that it matters is because as a nurse, you're going to need to know if, okay, so a beta blocker is going to significantly affect the heart rate, but a diuretic will not. So it might a little bit, but not to the extent that a beta blocker is going to. Do y'all understand that? Y'all understand? So we might not give a beta blocker if the heart rate, you know, is at 60, but we might still give that diuretic because we know that it's not going to have that same response. The body's not going to have that same response as it is when we give that beta blocker and we block that, block the, the body's natural response to that. So that's why y'all have to have a general understanding of how these medications work and those drug classes. At the end of the day, the action is going to be to decrease the blood pressure, but it's going to have a whole lot of other stuff that goes in with it, okay? We feel semi-okay before I move on. I'm going to share my PowerPoint. All right. Essence, you're the only one I see. Can you see types of drugs used for treatment of hypertension, number 1? Oh.
Yes, ma'am.
Okay. So I've already kind of told y'all all this stuff. Diuretics, beta-adrenergic blocking drugs, anti-adrenergic blocking drugs, anti-adrenergic blocking drugs. There's central and peripheral. Calcium channel blocking drugs, angiotensin converting enzyme inhibitors, angiotensin 2 receptor antagonist, vasodilating drugs, and then direct renin inhibitors. Those are relatively new drugs. I didn't talk about those. And then there's selective aldosterone receptor antagonist. Same thing, going to interfere at the end of the day with that, that normal response of ROS in the body. Oh, look at there. I already have it for y'all. ROS simplified. Renal blood flow is reduced, and kidney cells secrete renin into circulation. The liver produces angiotensinogen, which is converted into angiotensin 1. Angiotensin 1 is converted into angiotensin 2 by ACE. Angiotensin 2 is a vasoconstrictive peptide that narrows blood vessels and increases blood pressure. It also stimulates the secretion of aldosterone, which increases reabsorption of sodium, water in the blood, and it excretes potassium, thus increasing blood volume. So that's just a good thing to know, and it'll help you understand these drugs. All right, so antihypertensive drugs, we already know what they're used for. And I think I've kind of already told you guys all this stuff, but I'm just going to read out my slides to make sure that I didn't leave anything out, okay? So antihypertensive drugs, they'll either lower the blood pressure by dilating or increasing the size of arterial blood vessels. So let's talk about that briefly. If you have a lot of pressure in something, and you make that diameter wider, that pressure is decreased, correct? If you're trying to blow up a little bitty one of those water balloons, my kids always find water balloons and they want me to blow them up. And it takes a pressure because it's just tiny and the hole is tiny, as opposed to when you're trying to blow up those big giant balloons. The pressure is not nearly as much. So if we're increasing the size, if we're dilating those vessels, we're thereby decreasing the pressure placed on those walls. So that's how sometimes they're going to work. Diuretics increase the excretion of sodium, and so then that water follows, and then that decreases the pressure on those walls. The action of angiotensin converting enzyme inhibitors, they act primarily through the suppression of the renin-angiotensin-aldosterone system. They prevent or inhibit the activity of angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2, a powerful vasoconstrictor, by preventing the conversion of angiotensin 1 to angiotensin 2. So if you look at that ROS simplified and you just block out that step, that second to last step, that's how we know how ACE inhibitors work. And then here's some more. Action of angiotensin 2 receptor antagonists is to block the binding of angiotensin 2 at the receptor sites found in smooth muscle and adrenal glands, which stops the renin-angiotensin system and lowers blood pressure. And then so these are going to be used for the treatment of hypertension. Some are used only in the severe cases of hypertension, which we'll look at those in a minute. And then 2 antihypertensive drugs may be given together to achieve a better response. So a lot of times you're going to see that in practice where they're not just on 1 drug regimen, they're on 2, especially in a hypertensive emergency. Okay, so we talked about our little pink slide, I'll refer back to it. At the very beginning, we were like, you're telling me all this, but what is my job? This is what your job is. Your job is to look for your job is to monitor and assess continuously. You're assessing whether or not your patients need to, excuse me, whether or not your patients need to have this medication. You know, does their blood pressure warrant it, or do you need to call the doctor? You're assessing, you know, do they have some major adverse effects going on with these drugs? Are they having a dry cough? Are they getting incredibly dizzy when they stand up? You're the person that needs to report all those things and be the go-between person between your patient receiving the drugs and the physician prescribing the drugs. So when any antihypertensive drug is given, orthostatic hypotension may result, especially early on in therapy. So does anybody know what orthostatic hypotension is? I'm going to unshare my screen so we can talk for a minute. Okay, anybody? So orthostatic hypotension is, so the body has a continuous state of equilibrium, basically. You know, when we talk about, when y'all talk about like the blood range of like homeostasis, and you know your blood is 7.35 to 7.45 is the pH, and you know things change in the body, but it kind of finds its way back into that normal range there. The blood pressure is the same way. It fluctuates a little bit, but it kind of finds its norm from standing, sitting, lying. Orthostatic hypotension is whenever you go from lying down and you sit up and your blood pressure plummets. It goes like, it drops like 20 points systolic and diastolic. So 5 to 10 points, your body's not feeling anything. But when you go and you're lying down and your blood pressure is 115 over 60, and you sit up and your blood pressure is 95 over, you know, 48, you feeling a little, whew, you're dizzy. You know, you're having a moment. If you do that same thing and you lay down and you stand up, what do you think your potential is? What do you think could happen if you're dropping like that and your body doesn't have a chance to adjust in the midst of that? What do you think your patient's at risk for?
You could pass out.
Passing out, falling, injury, all of those things are a side effect when you're placed on blood pressure medication. Orthostatic hypotension is a real risk for your patients because we're interfering with those normal body responses, and the body sometimes needs time to catch up. You know, the body sometimes needs a chance to say, okay, whew. So what do you think that you would do? What is a way that you would instruct? Okay, so first of all, let's pause there for a second. Have y'all learned, well, if y'all didn't know what it was, you haven't. You're going to learn how to take orthostatic blood pressure readings. And what you're going to do, you're going to take a reading while they're lying. And then they're going to sit up and you're going to take a reading. And they're going to stand up and you're going to take a reading. All within 5 minutes. And you're going to report those to the doctor. You're going to do them every 5 minutes. Especially, so if a patient has a syncopal episode and they go into the ER, that's going to be your job as a nurse, is to do those orthostatics and report them to the doctor. Because we're not going to put this patient through a whole battery of tests if they're just, I don't want to say just having some orthostatic hypotension, but if this is something that we can pinpoint early on, right? We already know why they passed out. So that is orthostatic readings, is when you do it like that. And so your job, what is something that you think you can do? What is something outside of knowing anything else? What can we tell our patients to do to protect them? Does anybody have any ideas?
Sit up or sit slowly, especially like if they stand up, pause, and dangling, then they stand up.
Exactly. So when your patient is laying down, you're going to have them dangle when they go to get up. Dangle on the side of the bed for a second. Just sit there for a second. Dangle your feet, because your patients, if they're ready, they're, especially in the hospital, if it's their first time getting up, they're ready to blow and go. They're excited. They're like, whoop, whoop. I'm here. Okay, hold on, Mr. Jones. Let's just sit here for a second. Make sure you don't feel dizzy. Just hang out. We're not in any rush. Let's just hang out for a little bit. Distract them a little bit, then stand up. Before we start walking, let them get their bearings about them. Do you feel dizzy? No, I don't. Okay, well, let's go now. So something simple like that, but if you don't know that their medications might cause that, then you don't really think to say slow down. You might just be like, oh, I'm proud, you're going so fast, until they hit the floor. So that's what orthostatic hypotension is, and it is a risk with any antihypertensive drug. Okay. Back to my slides. Anybody want to say anything right now? Yeah. Oh, what's that, Kat? Oh, you're cutting out real bad. Try again.
Can you hear me a little bit better?
Yeah, it's cracking a little bit, but I can make out what you're saying.
What were the calcium channel blockers?
As far as the examples of the medications?
No, you described them and I missed that part.
Okay, we're fixing one of my slides coming up is going to go over that in a little bit more detail. Primarily, they're going to affect smooth muscle though, but I'm going to have a whole slide. I kind of gave you an overview so that I didn't just start talking and y'all were like, hold on, that's way too many words. I don't even know what you're talking about. So now basically I'm re-saying everything that I said, but I'm going to go with the slides. So you'll be able to see it in just a second. All right, let me share my screen again. All right, so ACE inhibitors, and if you want to take, when you print out your PowerPoints, this angiotensin converting enzyme inhibitors, we just call them ACE inhibitors. The main side effects of these medications are going to be GI stuff like dry mouth, gastric irritation, constipation, and the two biggest are cough and dry mouth. Patients who are started on ACE inhibitors can have that dry mouth and cough, and it can sometimes, remember we talked about compliance, sometimes it's enough for them to not want to take their medications, and so it's your job to investigate those things, or if they have a cough, helping pinpoint it to this, and then the physician may want to change their drug therapy. It's not always a deal breaker. A dry mouth is not always, it's always a benefit versus risk thing. So a dry mouth and a tickly cough might not bother some people, but it might just be obnoxious for people like me. Like if I had to cough every time I tried to lecture to you guys, I just couldn't deal. So it is very important that you pinpoint these things. So cough, dry mouth, ACE inhibitors, remember it forever. And so our angiotensin 2 receptor blocker drugs, some of the main side effects for those are going to be your central nervous system type effects like fatigue, depression, dizziness, and headache. And then it has some of those other side effects too, like abdominal pain, nausea, diarrhea, constipation, a lot of these side effects. So I kind of told y'all a little bit about my mama before. She seems to always have side effects from medications that she's prescribed. People are just some people are more sensitive than other people. Doesn't mean that all of these side effects are going to be accompanying all of these drugs, but they could happen. And so it's your job as a nurse to just collect that data and kind of know what you're looking for. So obviously, antihypertensive drugs are contraindicated in patients with a known hypersensitivity to the individual drug. So if our patient is allergic to one ACE inhibitor, they're very likely allergic to all ACE inhibitors. Same thing with if they're having some major adverse reactions, we're going to want to try them. And we're not the prescribers, of course, but we wouldn't anticipate them being on the same class. There's enough classes where they can be on something else if they have a hypersensitivity. ACE inhibitors are contraindicated in patients with impaired renal function. So we said that it inhibits greatly with that aldosterone, with that ROS system, right? The renin-angiotensin-aldosterone system. So it's contraindicated in patients with impaired renal function because we don't really need to interfere with that process in those patients. We need to target their blood pressure a different type of way. We're not giving these to patients with congestive heart failure or any problems with their salt and volume depletion. And that just has to do with its mechanism of action. Will you see patients with renal issues prescribed ACE inhibitors? You will. At the end of the day, it's not your choice to make because it's a risk-benefit kind of thing. But generally speaking, that's not their first line of treatment. And then the use of ACE inhibitors and angiotensin II receptor blockers during the first and second trimester of pregnancy is contraindicated. That is important to know. So beta blockers are safe for pregnant women. ACE inhibitors and angiotensin II receptor blockers are not. So your job as a nurse is to always know that pregnancy status and always be educating your patients. All right. We're going to use antihypertensive drugs very cautiously in patients with renal and hepatic impairment and electrolyte balances. We're going to use ACE inhibitors very cautiously in patients with sodium depletion, hypovolemia, or those who are already receiving diuretics. And then angiotensin II receptor agonists. We're going to use in patients with renal and hepatic dysfunction, with hypovolemia and salt depletion, and receiving high doses of diuretics. So at the end of the day, that's a whole bunch of words to say. We're interfering. ACE inhibitors and angiotensin II receptor agonists, they are interfering with that ROS system. So people who already have pre-existing kidney issues, they usually already have some kind of problem with that ROS system. They're either retaining too much sodium to begin with, or their aldosterone, all of that stuff is, those things aren't firing normally. So if your patient already has issues with hypovolemia, or they have issues with sodium depletion, or they have major renal problems, it would make sense why those drugs would not be the best choice for them. All right. I want y'all to look on page 400. I think it's probably going to overwhelm you guys if I read these slides that are coming up to y'all, but I need y'all to look at this box at the bottom of 400. I'm going to unshare my screen for a bit, and I'm just going to talk. When I start reading the slides, does it seem like a whole bunch of words and get overwhelmed? Does it help when I break it all apart and then go back to the slides, or is that making it more difficult for you guys? Okay, so we talked about at the very beginning on our first test, we talked about drug-drug interactions, right? So that's what this is saying. These medications are going to have the potential, antihypertensive drugs in general, are going to have the potential to interact with these other drug classes listed on page 400. NSAIDs, which you're going to learn about, rifampin, allopurinol, which is for gout, digoxin, loop diuretics, you don't have to write all these down, lithium, hypoglycemic agents and insulin, and potassium-sparing diuretics. So that's a lot of drug classes that they can interfere with, correct? Okay, let me tell you some of the things that they can do if they're given together. They can reduce the hypotensive effects, so they can either make the medication not work as well. They can decrease the pharmacologic effect, which would thereby also make the medication not work as well, right? If you're on allopurinol and you take it with an antihypertensive drug, it could increase your risk of hypersensitivity. So it could almost make you have an allergic type response if taken together. Let's see, increase or decrease plasma digoxin levels. So digoxin is a medication that's given for the heart. And if it's given in conjunction with some certain blood pressure medications, then it can make the digoxin not work. We can decrease the diuretic effects of some antidiuretics, making them not work. So remember when we talked about, remember I said 1 + 1 = 0? Remember we talked about that canceling out when we talked about additive and synergistic and all that stuff? So these are all real life examples of those words that you learned. Is that kind of pulling that in and making it make sense? For my exams, I won't be asking you. So if I point out something and I'm like, listen to me, you never give this with this, or you always, if you see this together, you always look at it. Luckily, and I'm not saying that it does not matter, luckily in our world, we live in a world with computer prescribing. So I'm not a big computer person. I want y'all to know that I like to see y'all and touch y'all and all that stuff. But as far as the world of computers prescribing, when a physician puts in an order, all of these databases will say that interacts with this. Do you still want to give it? So you have to have this knowledge because stuff does still get missed, but we have a whole lot of checks and balances in place for that. So the physician has a check that says, hey, are you sure you want to prescribe this? And then the pharmacist has a check that says, hey, ding, 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 this is an interaction. Let me call back and check with the physician. And again, it's a risk and benefit thing. Everything in life is going to be a risk. If we didn't give any medication that had a risk of interfering with something else, then, I mean, that's just not reality. But knowing this stuff is super important because you're going to need to listen to your patient and you're going to need to know that there are this many drug-drug interactions and there are this many drug-food interactions. Now, some of them, like I said, are deal breakers and you have to know them. This particular stuff, I probably won't pull out any major specifics from here. Okay, it's not a promise, but I don't want you to like lose your mind trying to study it. Okay, but I just really need you to grasp that just in those, that's just a few things thrown out there, and that's a lot of drug-drug interactions. You know, that's a lot of investigating that needs to be done on your part, right? All right, we good to move on? So basically all the slides that I'm reading right now are telling you all of what these interactions can be. Let's see. All right, gotta find my slide. All right, so hypotensive effects, you do need to know this, of most antihypertensive drugs are increased when administered with diuretics. So if we're giving something that's supposed to lower your blood pressure and something else that's supposed to lower your blood pressure, it makes sense that we might have a compounded effect and we might have a little more chance for that postural hypotension. Does that make sense to y'all? So that's kind of a common knowledge thing. Does it make sense? You shook your head no? Okay. All right, so we said diuretics are one form of antihypertensive drug, right? We didn't talk about them in depth yet, but they're one form of antihypertensive drug. So this statement says hypotensive effects, which means lowering of the blood pressure, of most antihypertensive drugs, all the other classes that I gave you, are increased when administered with diuretics. So if we're given diuretics and a beta blocker, our chance for that postural hypotension that I told y'all about is going to be more likely to happen because they're getting 2 blood pressure medications essentially. Did that bring you up to par? Did I confuse you more? Tell me, you're breaking up a little bit. Tell me again.
if you give them a diuretic and an anti-hypertensive drug,
Mm-hmm.
there's a chance that their blood pressure will increase.
No, well, hypo will be too low.
Oh, okay.
Yeah. So hypotensive effects, we want it to lower your blood pressure. We want to have a hypotensive effect. But we don't want you to be like super, super hypotensive. We don't want you to be like 80/40. So it's just saying the hypotensive effects of most antihypertensive drugs. So let's just, instead of saying hypertensive, we're going to say blood pressure drugs, just to make life a little easier. Hypotensive effects of most blood pressure drugs are going to be increased hypotensive effects, which means further decrease of hypotension, is going to take place if we give blood pressure meds plus diuretics. They're going to go down. Makes sense? It's the way it's worded. I think that's throwing you off. Okay. Let's see. I gotta sneeze again. It's not coming out. I'm probably gonna sneeze in the middle of talking. So many drugs can interact with the antihypertensive drugs and decrease their effectiveness. So we've already kind of looked at that box on page 400 to discuss that. ACE inhibitors, when they're administered with NSAIDs, reduce those hypotensive effects. Rifampin, I've already read all this to you guys. This is the box basically on page 400. I'm not going to read it again. All of this is in the box on page 400. Okay, so here is your job as a nurse. Pre-administration assessment. Before therapy with drugs starts, you have to assess the blood pressure and the pulse rate. We do not, so this is when it started initially. So I don't expect you, see where it says to assess the blood pressure and pulse rate in both arms in the standing, sitting, and lying positions. You are not going to do that every time that you administer blood pressure medication once it is already established, okay? You're going to just check their blood pressure. And if you have a discrepancy, you'll check it again. But you're going to always... but if you're administering it for the very first time, you want to be sure that you're sure that they need this medication. And that's going to be in the doctor's office type setting. And you're going to record it in the chart. You need to obtain a patient's weight because of the fluid and salt retention of diuretics. If they're losing or gaining too much weight too fast, then we need to reevaluate that therapy. So we're going to weigh them. We're going to check their blood pressure. For ongoing assessment, this is after they're after they're established on the drug, we're going to monitor and record the blood pressure, especially early in therapy. Each time the blood pressure is measured, use the same arm with the patient in the same position. The primary healthcare provider may order blood pressures to be taken in more than one position, like I talked about with the orthostatics. They may have you monitor the blood pressure and pulse every 15 to 30 minutes if a patient has severe hypertension and we're not getting the expected response of drug therapy. And we're going to have you assess the patient's weight and examine their extremities for edema. So when we're going through the nursing process, the expected outcomes are going to be that optimal response to therapy is achieved. So their blood pressure is back within normal range, that the patient's needs are met in relation to management of adverse drug reactions. So if something goes wrong, we're going to be quick to respond, and having an understanding of and compliance with the prescribed therapeutic regimen. That's all of our, when we're planning, that's what we want our outcome for our patient to be. So some diagnoses related to antihypertensive medications are going to be risk for deficient fluid volume, because with certain meds, we're going to be getting that excess fluid off through diuresis. Risk for injury, we talked about, related to the dizziness or the lightheadedness. Risk for ineffective sexuality patterns. So some drugs, we're going to talk about that in a little bit. Some antihypertensive drugs can cause erectile dysfunction, And that's super important. You know, people's sexual health and sex life is very important to them. And it's very often a reason why they choose not to take their medication. If they think that, you know, they're not going to be able to perform sexually, they're going to stop taking those meds. And it's your job to ask those uncomfortable questions. And then there's also a risk for activity intolerance, because we said that some of those medications can cause fatigue and weakness. All right, so I'm going to get out of that for 1 second, make sure y'all don't have any questions. Then we're going to talk about implementation. Then we'll talk about a few specific drugs. So are we kind of still feeling okay? It's making sense what these drugs do? Okay, thumbs up. Everybody give me a thumbs up. Well, I saw Miss Adams had some green, yellow, red stuff. I'm kind of jealous about that. I'm fixing to swap to Zoom. So we're going to go with the old-fashioned thumbs up.
I have a question.
Yes.
About the angiotensin 2 and like the pregnancy being in the 3rd and 4th trimester, would those women have to take a different type of blood pressure medicine?
Yes. So a lot of times, again, we're not prescribing, but we kind of just know this stuff in practice. Angiotensin drugs are not usually the first line of treatment anyway. Because so we're always going to start with the drugs. I say we, because we're not prescribers, but y'all know what I mean. Physicians are usually going to start with the drugs that are the most appropriate for their patient. So if you like, if my blood pressure was high and I'm still of childbearing age, a good physician will say, are you planning on having kids? Are you done having babies? Do you have, you know, what method of contraception do you use? And if it's even a likelihood for me to conceive a child, he's probably going to put me on a beta blocker instead, because I can take that beta blocker all the way through my pregnancy. You see what I'm saying?
See, I'm currently on Losartan HCTZ, and I'm 27. I don't have any children, but it's a possibility for me. And so I'm on that now. And so I was wondering, whenever I read that, I was like, yeah, that would be a problem.
So are you on contraception right now?
No.
Okay. Well, I mean, I guess that was a personal question to ask.
That's okay.
But
no, I don't care.
That's something for you to know. You know, ideally, you would find out that you were pregnant before you were in that 2nd to 3rd trimester. You know what I'm saying? But your job, now that you know that, is to say, okay, so if I get pregnant, I need to call my doctor about this medication. Right. You know what I'm saying? And again, it's certain. I'm not going to sit here and lie to you and tell you that I know without a doubt, like I know certain medications are more harmful than others. Losartan may be one that has a lower tetragenic quality than some of the other ones. You know what I'm saying?
Right.
And so that's something for me to tell you that I know those drugs that well, but I know it's in that big umbrella class. So I know that it is worth looking into.
Yeah, I think I'm about to get off of it now because my blood pressure is, since I've been doing CrossFit, my blood pressure is almost too low and I'm tired all the time. And it was like, I think it was like 105 over like 58. Like it's been like really low for me. So anyway.
So those lifestyle modifications may be enough for your blood pressure at this point. So you probably have a strong family history, huh?
I do. Everyone in my family. Yeah.
Yeah. Because I mean, you're a fit person, you know, so that goes to show you guys as classmates, you know, if you look at Emily, she certainly doesn't fit the bill for being on blood pressure medication at 27 years old. So that's another thing for y'all to know in your assessment of your patients is not everybody with high blood pressure is going to look the same or have the same lifestyle or, you know, all of those things, but definitely something to look into. But don't freak out because it may be one of the specific within that class that is not incredibly dangerous.
Right. Okay. Thank you.
But definitely good to know. All right. Any other questions? I really like real life examples, so definitely ask me if y'all have them. All right, we're almost done with this chapter, and then I'm going to tell y'all some ways to remember these specific drugs, okay? So I'm going to share my slide again. Going once, going twice, no questions? We good? Put my hair up, it's getting real. Let's see. Oops. All right. So nursing process implementation, administering anti-adrenergic drugs. So some of these drugs are going to be administered in patches, transdermally. So for these specific medications, we want a hairless area of skin. on the upper arm or torso. And these particular medications, the patch stays in place for 7 days. And a different part of the body will be selected before each application of a new medication. And if a patch loosens before 7 days, you can put a little piece of tape over the top of it. So this is specifically usually talking about the most common patch that's used is a clonidine patch. Clonidine. If we're administering vasodilating drugs, we want to monitor the patient receiving minoxidil because the drug increases the heart rate. So remember we said that not all drugs are created equal. So minoxidil is not a beta blocker. So you see that this particular drug is going to lower the blood pressure, but it's going to increase the heart rate, unlike some of its other drugs. So that's why it's important to know, if you have to know what you're looking for. Minoxidil is an emergency. It can be found on page, I think 407. Let me look. If y'all find it before I do, let me know. I don't see it on this list, but it's a medication that's given for severe hypertension. It's usually given IV. I'll find it later. But you need to monitor that patient. Administering vasodilating drugs, the primary care provider is notified of a heart rate 20 beats per minute or more above the normal heart rate, rapid weight gain of 5 pounds or more, unusual swelling of the extremities, dyspnea or angina. When we are administering calcium channel blockers, they may be given without regard to a meal. These are the drugs that can affect our stomach, the smooth muscle of our stomach, but if they get a stomach ache or any kind of GI upset occurs, then they can be administered with a meal. That's something that we can educate, to encourage their compliance. When we're administering calcium channel blockers, verapamil is best given with meals because of the tendency to cause GI upset. And then if we're trying to promote an optimal response to therapy, administering ACE inhibitors, we want to administer captopril 1 hour or 2 hours after meals. And then we talked about that dry cough that does not subside until drug therapy is discontinued. We want to ensure that a patient is not pregnant before beginning therapy. ACE inhibitors may cause a significant drop in blood pressure after the first dose, and this can be minimized if minoxidil discontinues diuretic therapy or begins treatment in a small dose. And then after the first dose of an ACE inhibitor, we want to monitor the patient's blood pressure every 15 or 30 minutes. So these are just some things that you can do as a nurse to implement. When starting these drugs, you can implement these things and kind of be on top of stuff. They can start taking them with meals if they cause GI upset rather than your patient just stopping taking their medications because of certain reasons. We want to ensure the patient is not pregnant. We already talked about that. We want to recommend that the patient uses a reliable birth control method. So sometimes they'll put you on these meds, and if you're on, you take your pill as normal, then they'll, that risk and benefit is equivalent, and the likelihood of pregnancy is low. So they'll still start you on those angiotensin II receptors. And then if we're given meds for hypertensive emergencies, we want to, in a hypertensive emergency, those medications are usually given IV push. So as an LPN, things are changing rapidly. Right now, you guys don't give those medications. That doesn't mean you never will, because you're going to learn to give IV pushes. So it's going to depend on, you know, the place in which you're employed and what their rules are. But for hypertensive emergency drugs, we're going to be monitoring those patients continuously. So like whenever I worked in pre-op, our kind of rule of thumb was they didn't go back to surgery if their pressure was greater than 165 systolic and greater than 95 diastolic. So we would kind of let them chill out and, you know, kind of recheck it. But if it was still hanging out, you know, close to the 170s and systolic close to 100s diastolic, we would give medications IV in pre-op to lower their pressure prior to surgery, you know, to decrease their risk of stroke and decrease all of that stuff. And when we administered those drugs, they had to remain on a pulse ox continuously, and we had to check their pressure Q5, you know, until they went back. So that's what these are the type of drugs that these are talking about with patients with hypertensive emergencies. And then if a patient is receiving a diuretic, we want to look for signs of dehydration and electrolyte imbalances, because sometimes meds can work a little too well, and we might need those dosages decreased. We want to encourage patients to drink adequate fluids. We don't want them to not drink because their Lasix makes them pee, and we're giving them medication to make them pee, and then they have stopped drinking, so they're compounding that. So the reason that the medication was originally given, we're kind of back to square one, and we need to go back to the drawing board. So you don't just tell your patient, oh, you'll pee less if you drink less. No, we want to keep them, you know, we want them to still obtain those electrolytes and drink as normal. And then, you know, they can still get their diuretic on top of that. Now, you will have patients that are on fluid restrictions and whatnot, but not every patient who's on a diuretic is on a fluid restriction. We've already talked about the risk for injury. You want to monitor and manage your patient's needs. If they're dizzy, tell them to rise slowly. We've already talked about that. We want to assist them getting out of bed with ambulatory activities. Other things that we might need to know, I've kind of already touched on all this, risk for ineffective sexual patterns. So we need to be in that, when we talked about initially, whenever I was telling y'all about educating your patients have to trust you, or they're not going to tell you that they stopped taking their medication because it was affecting their sex life. They're just going to low-key stop taking their meds and have a stroke, and, you know, they didn't tell them. So you have to make yourself approachable, and you have to make yourself, you know, to the point where your patients can say, you know, these are potential problems that can happen. If at any time you're having concerns about this, you know, let's discuss it, or let's refer you to this person, or let's talk to the doctor about some other options. But you're that go-between. As a nurse, that's kind of always been my thing as a nurse. Like, you're kind of that go-between person that that points them in the right direction. And then we talked about the risk for activity intolerance. And so, like you just said, Emily, your medication is making you a little bit tired, and that's interfering with your life. That's interfering with, you know, with you studying and you going to CrossFit. And so that's something that, as a nurse, you know, yes, you know, you need to go to your doctor and say, okay, like, I'm really tired. This is what's going on. And y'all can make a plan from there. But if your nurse is like, oh, that's normal, it's fine. It's fine. That's a good blood pressure. It's fine. You're not going to feel as comfortable telling her how you're feeling, right?
Yes.
And you're going to stop taking it on your own, and, you know, it'll be a whole deal. If headache is an acute problem for the patient, you know, give them a cool cloth. Give them, you know, a back rub. I know that doesn't seem realistic, but sometimes just getting somebody a cool towel and not blowing off their headache is a big deal. If nursing measures are not successful, then let the doctor know. So Tylenol doesn't always have to go, you know, getting an analgesic does not always have to be the go-to, darken the room and get them a cool towel. That can be your first go-to if your patient has a headache related to their medications. And then educating the patient and family on the importance of having a patient's blood pressure checked at periodic intervals once hypertension is detected. Patient teaching becomes an important factor as that blood pressure returns to normal. So like my husband, I'll be talking about him. He went from being totally healthy, and then he had a little bout of AFib last year around November. So he went from being totally healthy to, like I told y'all, being on these medications for his heart rate and his blood pressure and a blood thinner at the time. And so it's important, as his life has come back to normal, for us to check that blood pressure occasionally. It doesn't have to be on a daily basis, but, having a spot check of that blood pressure so that when we return back to the cardiologist in 3 months, we have some sort of idea of what his blood pressure has been doing in that interim. And so at the end of the day, when you're evaluating, we did the ADPI. So when we're evaluating, we want to know, was the therapeutic effect achieved? Is their blood pressure controlled? Have we identified any adverse reactions? Is there a fluid volume deficit? Is their weight fluctuating all over the place, or are we maintaining pretty steady there? Is there any evidence of injury? Have they fallen since they've started? And has the patient resumed sexual activity in a satisfying and normal way? And basically, this is just the answers to all those questions that we were assessing. Is the patient, this is what we want. Patient reports no decrease in activity intolerance. The patient reports no headache. The patient complies with the prescribed treatment regimen. They demonstrate an understanding of the drug regimen and the importance of compliance. Okay, so let's get out of this for a second, because I want to make sure before I think that the calcium channel blockers, remember I told you many drugs can have many different functions. I think they're covered very in depth in the next set of slides because they're also a mainstay of treatment for vasodilation and angina. So I think that's the main thing that it's covered. But I'm going to go to that slide since I know that was a specific question that we had, because I don't want to not go to it. So let me go to chapter 36. Okay, here we go. Can y'all see that anti-anginal drugs, calcium channel blockers? Can y'all see that slide? Okay, so I'm going to be going over this, but to answer your question, calcium channel blockers, their primary action is to inhibit the movement of calcium ions across cell membranes of the cardiac and arterial muscle cells, and they have effects on slowing the heart rate, slowing the conduction velocity of the cardiac impulse, depressing the myocardial contractility, and dilating coronary arteries. So they're primarily going to work on smooth muscle. And they're going to, when they relax that smooth muscle, they're going to dilate that artery. Does that make sense? So if we're talking pressure and the goal is to act on those calcium ions that generally cause that contraction, and they're relaxing, they're opening up that lumen of the artery. And if the lumen gets bigger, then we're decreasing pressure. If so that's how calcium channel blockers work. And then also same way, if we have the same amount, if our lumen is the same size, let's see, let me dump this little coffee cup out. I don't drink out of this cup. It's my little cup holder. That's why it looks gross on the inside. This is our little artery. So if we're taking some of the fluid out of this artery with our salt, like with our diuretics, it's a whole lot easier to pass through than if this was full of balled up paper, right? And sodium and all that stuff. So think of, when you think about your vessels and you think about blood pressure and you think about what we're trying to do, think about all the things that could make that pressure less. It'll either be dilating, relaxing, getting rid of some of that volume depletion. So those are how those drugs work. We'll talk about them because they're going to cross over into that other section of vasodilating drugs. So they're vasodilating and antihypertensive. Okay, I've been talking for a long time. I'm going to give y'all a break in just a second. I want y'all to look at the drugs on page 404. Start there. All right. Beta adrenergic blocking drugs. We understand, based on what I told you today, how they work in lowering blood pressure. Do you notice something on the end of all of those drugs? What do they end with?
LOL.
Yes, beta blockers end in OLOL. That is how you're going to remember those. Everybody say it out loud, write it down. Beta blockers end in OLOL or just LOL. Okay. You need to be concerned when you're giving a beta blocker about your patient's heart rate in addition to their blood pressure. And we generally hold beta blockers for a heart rate less than 60. And that makes sense to everyone, right? Because it's that full blocking of that fight or flight response.
What do you mean?
I say full blocking. What these medications are going to do when we give these medications, they're going to block that adrenergic response. I mean, you could still have it, like you could still go into fight or flight and all, but that's how there's the receptors that they're attaching to. So whenever you're given the medication, if you look at your MAR and a patient is getting metoprolol, your number one job as a nurse, before you give that medication, you got to know what their blood pressure is. You can't just go willy-nilly give a blood pressure medication because it's ordered. You need to find out your blood pressure. So whenever you find out your blood pressure, if your blood pressure is 130 over 70, it would warrant that medication, right? But if your heart rate is 50, and we know that this drug is going to further decrease that heart rate, and it's already at 50, then we need to hold that drug and we need to call the doctor. So you can't, as a nurse, you cannot decide at the end of the day if your patient needs to be taken off of something or if your patient needs to stop a certain therapy. But your job as a nurse is always to monitor and assess and call the physician with changes and clarifications. If you gave that drug, you're responsible when that heart rate plummets, because you're supposed to have the knowledge to know that it's not safe to give a beta blocker if your heart rate is at 50. Now, if you call your doctor and your doctor says his baseline is 53, I'm comfortable giving this drug, and it doesn't really have he's been on it for 7 years, and whatever, you can give it or whatever, because you got clarification. You're going to document that you got clarification. You're going to monitor the heck out of your patient. You know what I'm saying? Like, if you're going to find those certain judgments where if you just flat out don't feel comfortable, you can just say, look, doc, I just really don't feel comfortable giving this drug, and go from there. But if you decide to give it, your job from there, you got your clarification. You said, hey, I don't know about this. My knowledge tells me, XYZ. You document, Dr. So-and-so notified. And maybe let's not say 50. Maybe say it's 54. you know, it's kind of on that borderline of it could go one way or the other. Like it's not really going to hurt them if they drop to, you know, you'll document Dr. So-and-so notified, medication administered, we'll continue to monitor. And then 30 minutes later, to cover your behind, you're going to go check on your patient and you're going to check their heart rate. You know, heart rate maintained at 52. We'll continue to monitor. Can y'all see the difference of, oh, let me go ahead and do that, or let me go ahead and give this medication and their and their heart rate bottom out and you never even reached out to anybody to clarify. Does that make sense? That's why you need to know this stuff. So beta blockers, what do they end in? Unmuted and everybody tell me at the same time.
LOL.
Okay, beta blockers end in LOL, OLOL, however you want to say it, beta blockers. And we're always checking what?
Heart rate.
Heart rate, yes. We're checking heart rate in conjunction with blood pressure. Okay, anti-adrenergic drugs. So remember I told y'all whenever y'all make a little thingy-majigger. So anti-adrenergic drugs can be centrally acting or they can be peripherally acting. So if they are central, they just act on different portions of the autonomic nervous system. Centrally acting drugs, they don't have a specific ending. You kind of just got to memorize them. But the very most common one that I want you to know is clonidine. And that's on page 405. Peripherally acting anti-adrenergic drugs. Do we see what they end in? Most of them? OSIN. All right. Let's see. Then we have the alpha beta adrenergic blocking drugs. They're still in that adrenergic blocking drug category. They still end in OLOL. You see them? Those ones on the top of page 406. All right. Your calcium channel blockers. They're ending in PINE, P-I-N-E. And then you have two outliers right there. Diltiazem is a very, very common drug. You need to remember that it's a calcium channel blocker. It's on page 406. And verapamil is a common calcium channel blocker. They don't follow those rules necessarily. And this is just a way, you still need to be familiar. Don't just be like, every drug that forever ends in PINE is going to be a calcium channel blocker, but it gives you something to go off of. It gives you a basis to build off of. Our ACE inhibitors, what do they end in?
Yeah.
Y'all all see that? PRIL? Okay. And then angiotensin 2 receptor antagonists. What are they ending in?
Sartan.
Yes. Sartan or Artin. All right. So everybody, look at me for a second. Beta blockers, what do they end in?
OLOL.
Oh, well, all right. ACE inhibitors, what do they end in? I know y'all don't know them yet. Pril. ACE inhibitors end in Pril. OLOL, beta blockers, ACE inhibitors, Pril, and calcium channel blockers. Anybody?
PINE.
Yes, Pine. And then angiotensin, whatever, the last one. My voice is getting tongue-tied. Angiotensin 2 receptor agonist. What do they end in? Artin. You'll have to know that, okay? Don't just have to know the names of the drugs. You have to know, you have to be able to pick them out. You have to be able, if I give you a list of 15 drugs and I say put them in the box where they belong, I need you to put them in the box where they belong, okay? This is where flashcards and study tools and all of that stuff is going to come into play, okay? Blood pressure drugs are going to be the majority of the drugs. And this is just from that 1/3 truly seems like a low a low figure to me, about 1/3 of the nation having hypertension. Let's just say 1/3, I would say at least 2/3 of your hospitalized patients that you're taking care of, almost everybody is going to be on blood pressure medication, okay? So of all the drugs to really get a grasp of, these aren't, I'm not going to say they're the most important, but you're going to see them the most, and you need to, commit them to memory. So the next chapter, I'm not going to go on yet. We're going to get some water, some coffee, and have like a little 5-minute like absorption, 5-10 minute, like take a deep breath, chill out a little bit. And then we're going to move on to chapter 36. It is not nearly as much information because we've kind of talked about all those mechanisms of action. So it would make sense that a lot of the same things that take place when we decrease blood pressure would take place when we're having angina, which is chest pain, or when our vessels are dilated, right? So a lot of those actions are going to be the same. A lot of those drugs are going to be the same, okay? Same thing when we talk about diuretics. I don't know if I'm going to be able to cover diuretics today, but it's all of those mechanisms of actions are going to be the same essentially. So it's just going to be recognizing the drug names and kind of pointing out some of those teaching points. So it's 10:08. I'm probably going to keep y'all all the way until 11 today. I know sometimes let y'all go early, but we're going to be lecturing the whole time. So how we feel about like 10:15? Is that enough like regroup time for y'all? Go get a cup of coffee. Just kind of clear your brain a little bit, and then we'll come back. Any questions before I get my coffee? No? Okay. Y'all did good. Y'all hung with me. We might do a little, do y'all like, let me stop recording. Hold, please. Let's see. I'm taking up our time. I'll give y'all a few extra minutes if I talk too long. Do y'all like the Kahoot thing? Y'all like Kahoot? Okay, we can play like a little quick 8 to 10 question Kahoot game. So when you come back, before we move on to, because I was watching Miss Adams' class and I felt like it was way more fun than my class. I felt like my class was lame after I watched hers. I need some excitement in my life. I do have a little Kahoot game that we can play with the antihypertensive drugs. I haven't gone through, I looked through like the first 5 questions, so some of them may not apply, but it'll give us kind of a basis of where we're at before we move on to chapter 36. Sounds good? All right, y'all can have, let's do 10:20. Sounds good? 10:20. I'll see y'all in a minute. I'm looking for the Kahoot app. Hang on. All right, we are gonna do. I don't remember my Kahoot logon. My phone automatically does it, so I'm just gonna play from my phone, while y'all pray from theirs. Pray, play, whatever. I can't talk. Let's see, player versus player. All right, the pin is 852115. That's all y'all need, isn't it?
What was it?
852115. Y'all are making me want to eat real food. I started this terrible, I don't know, I guess it's not terrible. Started this hardcore diet crap and it does not taste good. And so I just ate my snack, my fueling, and I'm still sad and I still want real food. All right, missing one person. Brendan, Kat, Haley, Emily, Alexia.
What's the code again?
852115.
Will we be able to see the questions?
You should be able to see it from your phone.
Okay. I don't think so. I think we'll just be able to see the answer choices.
You sure?
Yeah.
That's lame. Well, you may read it loud. I'll figure out when I can't waste our class time trying to figure out my password because I don't know it. It's saved automatically on my phone. So I'll read them out to y'all and then we'll do it like that. And then I'll get it to where next time I'll log on from the computer and share my screen. All right, let's start. For severe hypertension, what class of drugs would you administer? Severe hypertension. Didn't go into this fully yet.
What
We can
are
only see color.
Oh, sorry. Red is ACE. Yellow is ARBs. Blue is calcium channel blockers. And green is vasodilators. Okay. So the right answer was vasodilators. And that's because they're actually making that lumen bigger. And so when we have severe hypertension, we don't have time to interfere with those processes. We just got to make that lumen bigger and decrease the pressure very quickly. But we didn't really talk about those yet too much. That's what our next chapter is about. All right. So what can y'all see on y'all's side? Y'all can only see
just the shapes? And
just the
colors.
shapes? Okay.
And the colors, yeah.
Okay. So does it help if I say shape or color? I'll go fast. All right. At least it's only 8 questions. So if it's a bust, we'll just do it different next time. All right. Which of the following medications is a calcium channel blocker? Red is lisinopril. Yellow is losartan. Blue is metoprolol. And green is diltiazem. We're looking for a calcium channel blocker. They end in something, but they have some outliers.
Can you say it one more time? I'm probably gonna miss it.
Lisinopril is red. Y'all are out of time. Diltiazem was the right one. Lisinopril. Pril is what? Y'all tell me. Pril. Prils are ACE inhibitors. Losartan. That's your artans with your angiotensin 2 receptor antagonist. Metoprolol, OLOL, is a what?
Beta blocker.
Yes, ma'am. And diltiazem is one of your outliers. Most of your, oh, look, I thought I stopped recording. Hold on. Did I record our whole?